Yeah, thanks for the kind introduction. Yeah, I would love to know the future. I just have some idea to share, which I could envision or I think is on the schedule to be used. So what is the current status? And just if you think about future, you need to analyze the current situation. The current status of acute GvHD disease is still, if it gets above grade 2 and is steroid refractory, the prognosis is dismal. Here is a publication from the Shannon Holton group. Here are data from our group, unpublished data. And if you progress from 2 to 3, or you just develop grade 3 or 4 GvHD disease, your prognosis is just dismal. And when we looked at our results in Regensburg on the survival of steroid refractory grade 3 or 4 GvHD disease, we made the unpleasant experience that the mortality for the last 20 years didn't change much. The rate of those patients declined, yes, and the survival improved, but the overall long-term mortality is still unacceptable high. So that's a very urgent need to have more effective treatment, not adding to treatment-related mortality in those cases. And as we already discussed, we need to identify the patients early on and treatment early efficient, not to allow long-lasting severe acute GvHD disease, which would probably not be reversible. How about chronic GvHD disease? And this is a nice publication from Zahariya De Philippe, from a very recent publication from the American cohort, looking at the patients over time and with regard to treatment-related mortality and relapse. And the disappointing issue was that we lose a significant proportion of those patients, in part of relapse. So we need to work better on immunosuppressive agents or strategies which do not increase the relapse risk. But treatment-related mortality, so in the absence of relapse, is substantial. And this is frequently due to infections complications, but in part also to chronic GvHD disease itself. So don't forget that, for instance, severe lung disease can lead to pulmonary failure. And we clearly need, and this is indicated by the data, less toxic and more efficient treatment without impairment of graft-versus-leukemia in chronic GvHD disease. So we need still to think about both, not only treatment-related mortality, but also relapse. So what is my outlook in treatment of acute GvHD? As already commented through the case discussion, I think one fits all does not fit with acute nor with chronic GvHD disease. And we just started 1.5 years ago, initiated from Hamburg, and risk-adapted first-line treatment trial evaluating ECP plus steroids in those in patients with a high risk for treatment-related mortality, and we are eager to see the results of this trial and to look whether this improves the prognosis of this high-risk population. How about second-line treatment of acute GvHD disease? I and we all probably regard ECP as a very valuable option in patients with high risk of infectious complications, cytopenia. And if you look at the REACH2 trial, even when that ruxolitinib had a superior response rate, ECP was second best in terms of failure-free survival. And if ruxolitinib is contraindicated in those patients, ECP is a very valuable option, just shown by the randomized trial. ECP may be also an option in patients failing ruxolitinib. Hildegard Kreinex just shared the data published on that issue. And just keep in mind, ECP may be also combined with other immunosuppressive approaches, as like ATG or mesenchymal stem cells. The beauty of ECP does not add toxicity and spare steroids, which we all agree are toxic on the long run. And of course, we would like to know biomarker predicting response of ECP, and there's an NIH study going on to evaluate those the responses of ECP in correlation to biomarker, and we really would like to know the results of this trial, because that would also aid to select the patients receiving ECP. How about the outlook in chronic GvHD disease? We already discussed the issue that chronic GvHD disease is not all the same upfront. We do know features which result in high risk for treatment-related mortality, like lung involvement, lower GI involvement, liver involvement with an elevated bilirubin or low platelets or progressive onset. And Hildegard Kreinix just started a trial or evaluating in this context, upfront ECP. How about second-line treatment of steroid refractory or dependent chronic GvHD disease? Again, that's the same situation like in the REACH2 trial, where we do deal with patients who are at high risk of infectious complication or are cytopenic and have a contraindication for ruxolitinib. And for those, again, ECP would be a very valuable option. And it has clearly also a higher efficacy compared to other best available treatment options, and does not add toxicity. And as in acute GvHD disease, third-line treatment in patients failing ruxolitinib is still a challenging issue, and combination with ruxolitinib or replacement of ruxolitinib by ECP is an option which continues to be important. What I would really advocate for is an approach which actually Hildegard Kreinix developed together with other co-workers during the NIH Consensus 2020. One of the challenges is that we would all like to know which treatment works in which patient, and that this would require the identification of predictive biomarker predicting the response. And one way to target that would be to perform a trial, optimal upfront treatment trial, where you analyze the biological profile of the patient and analyze the clinic and start the treatment optimal with a monotherapy, so ECP would be an ideal candidate, and look after 4 to 8 weeks what happened to the clinical phenotype and what happened to the biology of the patient. And for instance, analyzing biopsies, analyzing cell fractions, cytokines. And by doing this, try to identify in a low number of patients what the treatment changes with the phenotype and the biology, and to use that in future as an identification tool or a predictive biomarker or predicting the response in individual patients. Why ECP? It's safe, it's efficient, and it's associated with a good quality of life. And if the patient controls for it himself or herself, you don't need a large number of patients, because you can assess in a single patient change over time. What would be my hit list for the question to be addressed for the next years? As I already pointed out, does risk-adapted first-line treatment of acute and chronic GvHD disease with ECP improve outcome? That would be something which we all would like to know, and we all acknowledge that the best thing would be to treat the patient's upfront efficiency, not to risk several lines of treatment which go on the expense of the patient's quality of life and side effects. Then, as I already pointed out, develop predictive biomarker predicting the response to ECP. We should also in future systematically explore the combination of specific agents, including ECP, for synergistic effects. One of the colleagues asked in the chat what we could think of, and here are just some examples. Some are already explored, some may be interesting, like the combination of ECP and belomucil. And don't forget the children. Children are especially challenging because there are a low number of patients at the other side. At the one side, at the other side is if chronic GvHD disease affects children, that's a nightmare, because exposing a grown child to corticosteroids and other immunosuppressive agents and organ damage is just a nightmare. And we already know by limited data or increasing number of data that ECP is an effective treatment in children and with low side effects, and may have a central line anyway because of treatment. So this is not an issue. And we would like to know whether mini ECP would be possible in those children, and also to compare new approaches like the use of fresh versus frozen cells and the effect of schedule. Some of the colleagues in the chat already asked for that, and we have to acknowledge that we still don't know the ideal schedule, especially in chronic GvHD, while we already know that intensive treatment in acute GvHD is probably, or it's more effective than a low frequency approach. Those are all thoughts for the future, and or at least to-dos for the future. And we all would love to know the results of those trials and questions to improve the outcome of our patients.